Okay, so you can start now. We have kept the time 6 minutes.
Yeah.
Okay, start.
Okay. So today I saw the video of a boy who looks well grown for his age in the hospital setting with the IV cannula on the right hand. And I can see mostly he looks like ill looking. And there is obvious swelling which is visible on the left eyelids. And also in the compared only on the left side, right side, there is no swelling. And there is also conjunctival congestion I can see. And there is restriction of movement of the eye, both upwards, laterally, and also medially compared to the right eye.
Okay.
And he is receiving some IV injection.
Okay, IV medication. Okay, then.
Yeah. Then
tell what history you want to take in this.
Yeah, I would like to take the history about the onset, duration, and progression of the illness. Any pain over the eye, any fever, any difficulty in the vision, vision if it is affected, also any difficulty in the color vision also, and also any associated headache, any underlying ENT problem, like any cough, cold, any chronic sinusitis or ear infections, and associated with any vomiting, headache.
Okay.
These symptoms I would like to.
Okay, tell me about examination. What examination you want to do in this patient? Hello?
Underlying illness.
Yeah, okay.
In the history.
Yeah. Examination.
In examination, I would like to do the complete examination, including the vitals of the child, including heart rate of the child. And I would like to examine complete eye examination, including field of vision, visual acuity, any ophthalmoplegia to look for, okay. And also fundoscopy I would like to do in this child, and any pupillary reaction also. Also, along with that, I would like to complete with complete neurological examination in this child. Okay. And ENT, neurological and ENT examination. And I'd like to plot his weight height in the growth chart.
Okay. So then give me your differential diagnosis for this case.
Yeah, as it's a unilateral swelling, so my first differential diagnosis is it could be because there is a restriction of movement, it's a case of orbital cellulitis or severe form of periorbital cellulitis. Third possibility, I would like to also rule out if there is any trauma, history of trauma, any insect bite.
Okay.
And any underlying, any like malignancies, which can cause unilateral swelling.
Okay. So give me your investigations and management plan.
In general or specific?
I want, if this is orbital cellulitis, give your investigation.
Okay. Yeah, investigations, I would like to do the complete blood count, CBC, CRP, blood cultures, and also any swab to be taken from the eyes, and for the culture sensitivity, and CT of the orbit in the investigations. And this needs, after taking complete history and examination and involving my consultant, this child needs multidisciplinary team involvement, and immediate management should be done as the infection spreads very fast. IV antibiotics should be started, and also the ophthalmologist and ENT surgeon should be informed immediately about the case. Yeah.
Okay. Can you tell me the choice of
and also analgesic? Yes. Yeah, Choice of antibiotic for orbital cellulitis, it is ceftriaxone plus clindamycin. Clindamycin they add when it is very severe, they add clindamycin. And yeah, this, and usually they continue for at least 2 to 3 weeks.
Okay.
And
if it is periorbital cellulitis, what is your choice of antibiotic?
if it is mild, then it is oral amoxiclav, amoxicillin clavulanic acid. If it is severe form, then IV amoxicillin clavulanic acid, still stabilized, then they change to oral medication.
Okay. I will see that.
And also here to cover analgesia, analgesic should be given because it's painful condition. And this ENT ophthalmologist will decide if anything needed for the drainage of the, if needed.
Okay, you said ENT examination. What is the importance of ENT examination in this case?
Because sometimes chronic sinusitis or underlying chronic ENT problems can lead to this orbital cellulitis. And
okay, time finished, but still no problem. Just tell me. Okay, sinusitis and
yeah,
this is the reason. Okay, I think time finish. Yes, your description was right, but I want to ask, in the video station, they will give us some cue like the age of the patient and any presentation, one sentence or anything. I don't know.
Yeah, usually they give.
Like, for example, for this case, like 10 years old boy presented with eye swelling like this.
Yeah, eye swelling or eye pain, something like this.
Okay. So your presentation was good. You started describing that he's a well-grown boy, and he had swelling only in the left eye, and there was conjunctivitis also, and there was problem in the upward and lateral, but I doubt about medial. He was able to see medially when you
yeah, but when you compare with the right eye, there is some movement is there, but not complete like right.
Okay, no problem. Anyways, there is, ultimately there is ophthalmoplegia in this child. This was detected by you, and also about the IV cannulation was described, hospital setting was described, and medication giving was described. What we see should describe exactly whatever we collect the points. Maybe in the video, they may also add any temperature if he has like 38.5 or whatever, if it is there, or any readings on the monitor we will tell. This is okay description. Then history, you started with onset, duration and progression. Then you will ask about the history of fever and pain and years, you said, infection you said, but I don't know during the history you told about trauma or not. I don't know. I don't remember.
Yeah, I asked about trauma.
Okay, you asked. Okay, maybe I missed. Then examination, yes, we will start with the vital signs of the child. If the child is very severe, we'll start with ABC. If not vital signs, check for the heart rate, blood pressure, temperature, everything. And then complete eye examination is very important here. As you said, visual acuity, visual fields, and also color vision is important here. Can someone tell why color vision is important?
Yeah, vision, it will be affected in this.
Yeah, usually they will also check the monitor. Initially, they will be monitoring with the color vision. How fast is the progression? Okay. So color vision is also important here, along with visual acuity, visual fields, color vision. Then you will check for the eye movements, that is the head-shaped eye movements, and also the fundoscopy. Neurological examination for any neurological deficits, and ENT. ENT, she told sinusitis. What else you could have given in your differential diagnosis? You said orbital cellulitis, periorbital cellulitis, insect bite, trauma.
And malignancy, I told.
You can tell
Unilateral.
CNS tumors also, right?
Yeah, yeah.
more about even above the malignancies, you can give here the CNS tumor can be even there can be optic glioma or
Retinoblastomas also can come up like that. Even the infiltrative conditions of the eyes, even they can come up like that.
yeah.
And vascular would be cavernous sinus thrombosis as one of the differentials can also come up with this. As she rightly said that we are going to monitor the CNS to see for any focal neurological deficit because it can be one of the complications also.
Yeah. Monitor CNS as well as a complete CNS examination for any neurological deficits. And also the fundoscopy, again, you will check fundoscopy for any features of raised intracranial pressure, which will give you. And also if there is any tumor, because the optic glioma can also produce the proptosis and ophthalmoplegia, right? So this also you have to keep, and even the retinoblastoma, but retinoblastoma will have early presentation, not so late. So you can just give us CNS tumors as your differential diagnosis. Okay.
Okay.
This is one which was missed. Otherwise, I think you did well in the investigations. Yes, it's just simple CBC, CRP, blood culture, and the CT, and also you will go sometimes to MRI. And in management also was covered. So we will just go through the leaflet so that we will not forget the points. Okay.
Okay, so what all things you will look in the vitals, especially heart rate, blood pressure, and respiration, whether it's regular or irregular, to look for any signs of increased intracranial pressure.
Yeah, increase intracranial pressure you have to check. So all the vitals you will take. What you take.
Especially if he asks, then these three things, because these are the part of Cushing's reflex.
Okay, heart rate, blood pressure. What else you said?
Irregular, whether there is an irregular respiration.
Okay.
Dr. Noor, just one point. I think we have to set malignancy broadly because in addition to CNS malignancies, we have leukemia with infiltration to the eye, also coming the differential.
Yes, here the top will be orbital cellulitis. Periorbital also you can put it down when there is ophthalmoplegia. Okay. So the top will be orbital cellulitis. Then even the periorbital and insect bite, you will keep it, but I don't think they will present with ophthalmoplegia like this. But orbital cellulitis itself can be a complication of insect bite, right? Secondary infection. And trauma, CNS tumor, and malignancies. So anything else you want to add?
Dr. Noor, looking at this picture, which nerves we will comment are involved? Movements as far as concerned is which nerve seems to be affected? The third, fourth?
Okay. Can you replay the video?
Here it was lateral rectus and I feel inferior oblique, because upwards and outwards the eye was not going and the eye was not moving laterally. But here it is due to the increase in the pressure, right? Increase in the pressure inside the eye. There is a pressure effect on the muscles and the nerves both. And also there won't be any particular type of ophthalmoplegia like you see in a particular nerve palsy. Like in fifth nerve palsy, you will see only lateral rectus, right? Here, this is due to the changes inside the eye. You may have more than one.
Yes, right.
Comments, Dr. Sridevi, you want to give on this? Hello? I don't know, maybe she's not there. Or anyone else? I think this won't be any particular clear nerve like fourth nerve palsy, third nerve palsy. No, it depends upon how much of the pressure is built up and where the nerve is compressed or the muscle is also compressed. If both is there here.
No, that's right. But looking at the video and the movement,
This video, for me, he was not able to see laterally and upwards. It was clear when you compare to the both eyes. If you want, I will play again. And for me, medially was okay, but Dr. Sridevi said even medially there is some affection. Okay. After going through this leaflet, I will play the video. Okay. So this is only one page of orbital cellulitis. I think if we remember this, it's enough. And this case, I think, has come once in the history station also, orbital cellulitis. Okay. So it's good to go through this. So there is preseptal cellulitis and the orbital cellulitis. I think preseptal is also known as periorbital, right? We have facial erythema and tenderness. Here there will be painful eye movements. So when in the history, all these points you can ask, like if about his eye movements. And let me first read about preseptal and then orbital. Okay, so there will be facial erythema and tenderness. Here you will have painful eye movements, normal eye movements here, and here there will be orbital pain and tenderness. Here normal vision, there will be visual impairment, red and green color differentiation lost early. So in your history, or sorry, in your examination, always tell that along with the visual acuity, visual fields, color vision, pupillary reflex, and examination of eye movements, don't forget color vision. Okay, you will tell complete ophthalmological examination along with the, if you want to mention step by step, say everything, including color vision. Okay, so visual impairment, red and green color differentiation is lost early. Here in preseptal, there will be normal vision. So here there can be preceding superficial trauma in the preseptal also, and in the preseptal there can be eye pain, periorbital swelling, and fever. Here what other you things in orbital? Proptosis, chemosis, ophthalmoplegia, and preceding sinusitis. That is why ENT examination and asking about the pain in the ear, nose, throat becomes important here. Okay. So again, we will concentrate on orbital, painful eye movements, orbital pain and tenderness, visual impairment. Early is the red and green color differentiation lost early, proptosis, chemosis, ophthalmoplegia, and sinusitis. If uncertain, manage as orbital cellulitis, pending CT and ophthalmologist review. Now you're confused whether it is preseptal or orbital. Better to think it as orbital and start your management, awaiting CT and review by the ophthalmologist. So eye swab is very important, which was told by Dr. Sridevi, and then regular CBC, CRP, blood culture, and CT scan. If they ask you for the indications of the CT scan, orbital involvement is suspected, central neurological signs, unable to assess eye movements or vision, or if eyelid cannot be opened, it is so much edematous and so much closed that you cannot open the eyelid and you cannot assess the eye movements, then you will definitely go for CT, despite whether you know or don't know there is pain on eye movements and ophthalmoplegia is there or not. Then bilateral edema, deterioration despite treatment. So these are the indications for CT scan. If you suspect orbital involvement, if there are any other neurological deficits, unable to move eye movements or vision, and also because the eyelid is so much closed that you cannot open, then bilateral edema, deterioration despite treatment. MRI if neurological signs or suspicion or evidence of intracranial involvement on CT. So you will proceed with MRI if there is evidence of intracranial involvement, that is any complications from orbital cellulitis. Okay, I want to ask anyone why this bilateral edema he's telling he needs to go to CT, because of the basal skull fractures or anything. Bilateral edema can also come in some disorders like nephrotic and others, right? Maybe this is for the basal skull fracture. This is my thinking. Anyone wants to comment on this?
Is it cavernous sinus thrombosis or something? I don't remember, but just asking.
Maybe, or sometimes after trauma, even if you have bilateral edema, you should be careful of any fractures. But in cases of basal skull, you will it will not be just edema. It will be clear like bruise, right? Panda eyes.
Mm-hmm. Yes. Raccoon eyes.
Raccoon eyes, yeah.
Same.
So management, there are two things here. Preseptal periorbital cellulitis or orbital cellulitis. So for preseptal, if limited to upper eyelid, oral. If just upper eyelid is swollen, you'll just give oral coamoxiclav. Review eye movements and red-green color vision twice daily. So you'll be following up whether the preseptal will go into orbital. So this is very important. So how do you review for this? Eye movements and the color vision, red color vision twice daily. Because if here we read upwards that the differentiation is lost early. That is the color vision. So you will be assessing twice color vision and the eye movements. If both eyelids severe or no improvement after 48 hours, give IV coamoxiclav, okay? And it is severe and you are showing no improvement with oral amoxiclav, you will shift to IV amoxiclav. If improving, convert to oral high dose coamoxiclav. If penicillin allergy, give clindamycin. This you should always remember. If penicillin allergy, clindamycin. Total duration of treatment is 14 days here, okay? For orbital cellulitis, I think it is 3 weeks. That is 21 days. Orbital cellulitis, urgent ophthalmology and ENT review within 4 hours of assessment for surgical drainage. So when if you have been told that if this is orbital cellulitis, how do you manage? You will tell that after this basic vital signs heart rate, you will involve your consultant and ophthalmologist, okay, at the same time. And you will take the basic labs, and after taking for the blood culture and basic labs, you will start with the IV antibiotics. And involvement of your consultant, ophthalmologist and ENT review as early as possible. This you have to mention. So urgent ophthalmology ENT review within 4 hours for assessment of surgical drainage. IV ceftriaxone 100 mg per kg. This is the maximum dose, okay? Maximum is 2 grams, or the other option is cefotoxime 50 mg per kg, maximum 3 grams if ceftriaxone is contraindicated. Then if the child is toxic to this ceftriaxone, you will add clindamycin. Okay, 6.25 to 10 mg per kg, 6 hourly. Usually ceftriaxone single is enough, but if the child looks more toxic and ill, you can add clindamycin to it. If history of anaphylaxis to penicillin, give ciprofloxacin and clindamycin. Okay, instead of ceftriaxone, you can use ciprofloxacin. If improving, convert to oral high dose coamoxiclav. Okay, suppose the patient is improving with your treatment, you can convert to high dose augmentin. If penicillin allergy, give clindamycin. Total duration of treatment, including IV, will be 21 days. Up to 6 weeks if bone involvement. Okay, if there is involvement of bone, then you have to continue up to 21 weeks. Whatever may be the duration of ceftriaxone, maybe you gave ceftriaxone for 5 to 7 days, then you wanted to change to oral high dose coamoxiclav, but total duration of your antibiotics will be for 21 days. Then if there is bone involvement, it will be 6 weeks. Next is the intracerebral complications. So you will also have to involve urgent neurosurgical. So the team here will be ophthalmology, pediatrician, ophthalmologist, ENT, and neurosurgery also if there are complications. So sinusitis, URTI symptoms more than 10 days or more than one of nasal congestion and discharge, persistent cough often nocturnal. If acute, treatment with amoxicillin, change to co-amoxiclav if no response after 48 hours, IV if severe. Total 7 days of antibiotics. This is for sinusitis, he's telling. Severe if falling GCS, temperature more than 39 degree and purulent discharge. ENT neurosurgical review. If complications are present, orbital CT with contrast. Neurological complications, you will go for MRI with contrast. Okay, so if there are complications, you will go for CT with contrast, that is orbital. And if there are other neurological complications like neurological deficit, focal neurological deficit or something, you will go for MRI with contrast. Plain CT of sinuses for sinusitis, if stable, can be done as outpatient. Okay. So tell about the complications you expect in orbital cellulitis. One is the cavernous sinus thrombosis. What else? There can be abscess.
Yes, pain, abscess, meningitis.
Meningitis, encephalitis. So any signs of the increased intracranial tension and focal neurological deficit, you can go for MRI with contrast. Okay, if there are local signs, increasing in local signs, you can go for CT with contrast, that is orbital. So any comments? Video.
That video you had told you would be showing, is it possible?
Yeah, I am trying to show now. 1 minute. So here there is the swelling here in the left eye. There's also proptosis. Go so fast. So did you see Dr. Jaiprakash and Dr. Krishna?
Yes.
Yeah, what do you think now, the eye movements?
On the left side, he can move this the inner side means medially as well as laterally. There is no restriction, but on the other end, in this there is a restriction upward movement and also this downward movement. Means this is the third nerve, and also this appears the sixth nerve involvement.
Now you see, he can see down. Up he cannot.
Yeah.
Up he cannot. The other eye is moving up, but this eyeball medially he can.
Laterally also.
Laterally he cannot.
He cannot. You see, the other eye is this side, but laterally he's not going.
Completely not going. Yes.
Yeah. So this is lateral. But you see, even the inferior oblique is supplied by which nerve? Oculomotor nerve, right? Yeah, but we could not say the amount of involvement. As I said, depending upon the pressure and how much it compresses on the nerves and also the muscles, there will be different presentation here in orbital cellulitis. Not like a single clear nerve palsy.
Yes.
Yeah.
Thank you.
So when you suspect the meningococcemia and it is sepsis, what is the immediate management? Okay, we'll just go through the management. There are other criteria up like when do you suspect, low risk criteria, high risk criteria, and moderate risk criteria. All those things we can read by ourselves. This is 4 pages on sepsis. We'll just go through the investigation and management, which will be the most important thing asked. Other things we know to ask in the history, examination and everything, most of us will know. The only thing which will change usually will be the investigations and management, which we should be updated always with the recent things. Okay, so we'll just go through this fast and we'll finish this meeting for today. So always in these cases who are toxic and baby looks toxic, high grade fever with purpuric rash, go with assess airway, breathing, circulation, and don't forget glucose. Always glucocheck is very important. A, B, C and glucocheck. So here he has made A, B, C, D. Airway, breathing, circulation, don't forget glucose. So treat immediately, less than 1 hour, as delay increases mortality. Give oxygen if suspected sepsis, signs of shock, or SpO2 less than 92% in air. So sepsis, signs of shock, and SpO2 less than 92%, you will start oxygen. High risk, give IV antibiotics at maximum recommended dose within 1 hour. Discuss with consultant, arrange immediate review by senior clinical decision maker. So usually he should be ST4 and above, more than or equal to ST3. So usually the important you will tell here is give IV antibiotics within 1 hour. Okay, you will involve your consultant as soon as possible. Then investigations, which we all know, it will be CBC, CRP, blood culture. Clotting screen becomes very important here, and meningococcal PCR. Okay. And also you will do the blood group and save, and urea electrolytes. Other extra things here will be cortisol. Glucose you have already checked in the starting. Blood gas, and you will comment on the lactate. It is very important. Okay, when you say blood gas, you will also look apart from the pH, the bicarb, and the you will also look into lactate. Tell this, it is very important. So in the investigations, you will go CBC, CRP, blood culture, meningococcal PCR, clotting screen, blood group. You will and you will be saving the blood if needed, urea and electrolytes, CRP, glucose, gas. Cortisol, I don't know why. Anyone can tell me?
Severe sepsis causing adrenal insufficiency or something like that.
Maybe because there is one syndrome, no? In meningococcemia or something, there will be
That
Waterhouse
Waterhouse Frederickson.
Yeah, this one. I mean, this is my doubt also. Okay, so lactate. Comment on lactate always. If lactate is more than 4 or systolic BP less than 90, if aged more than 12, give 20 ml per kg IV fluid bolus isotonic crystallide without delay. So in blood gas, lactate more than 4 or systolic BP less than 90 and the child is 12 years old. So you'll start 20 ml isotonic saline, normal saline usually. If lactate 2 to 4, give IV fluid bolus 20 ml per kg isotonic crystallide. Example, sodium chloride 0.9%. And if neonate, make it 10 to 12 ml, 20 ml depending upon your thing. Reassess after completion. If no improvement, repeat. If no improvement after second bolus, alert consultant to attend. So first bolus, second bolus, try to involve your consultant. Use human albumin solution 4.5% for fluid resuscitation only if patient with sepsis with fluid refractory shock. Means you have given maybe 3 boluses, 20, 20, 20. Still there is no there is refractory, you can consider albumin. Okay, this is just to remember. Mainly, I think you will start with ABC, do these investigations and IV boluses, and you will involve the consultant. This is what you will tell. And also first step you can do within 1 hour, you can start antibiotics once you take the samples for cultures. So discuss with critical care, call anesthetist for ventilation, invasive monitoring and central access. Peripheral access only. If there is peripheral access only, you can consider dopamine. Okay, I will not go into the doses. So if there is central and intraosseous access, you can use adrenaline. Okay, so for peripheral access, you will use only dopamine. If there is central access, you can use adrenaline. If there is a fall in blood pressure, and also you will call the anesthetist as standby for needed for intubation or ventilation. If lactate less than 2, start IV fluids. Carry out observations every less than 30 minutes and monitor the mental state for Glasgow Coma scale or AVPU scale. Consultant to attend in person if not already present. Okay. Next is we will go for if lactate not decreased by more than 20%. And decreased level of consciousness and respiratory rate or systolic BP still high risk, then you will go for again the severe management. Okay. So if lactate is more than 2 and equal to 2, moderate to high risk criteria, perform venous blood for blood culture, CBC, CRP, UE, gas for lactate, and clinicians and results review less than 1 hour. Okay, if lactate more than 2 or assessed as having acute kidney injury, escalate to high risk. So high risk, again, we read the treatment here. Mainly what we will tell is after taking the labs, giving the IV antibiotics and giving the first dose bolus, you will involve your consultant. Okay. So let's go to the antibiotics, which we should know. Okay, and they can ask, maybe if not doses, at least the name of the antibiotics we should know. Okay, so for antibiotics, give IV antibiotics to infants aged less than 3 months as follows. Okay, infants aged less than 1 month with fever, all infants aged 1 to 3 months with fever, moderate high risk. Okay, so infants aged 1 to 2 months with WBC counts less than 5,000 or more than 15,000. So you can consider the antibiotics. Take microbiological samples before prescribing any antimicrobial within 1 hour of meeting the high risk criteria. Review prescription when results available. If suspected sepsis, take blood cultures before antibiotics are given. Follow local antibiotic guideline. So we all know we will do this. Just we'll go for the empiric antibiotics. Ceftriaxone again in high dose, 100 mg per kg. Daily over 30 to 60 minutes. Maximum dose depending upon the weight of your child will be 4 grams in these sepsis cases. Otherwise, it will be 2 grams, right? Normally it is 2 grams, but in cases of sepsis, it can be considered up to 4 grams or 100 mg per kg. Similarly, cefotaxime 50 mg per kg, maximum is 3 grams and it will be IV bolus. Do not give ceftriaxone with calcium IV less than 41 weeks post-menstrual age. Neonate with hyperbilirubinemia, hypoalbuminemia, jaundice or acidosis. If documented history of definite anaphylaxis to cephalosporin, you can use vancomycin or ciprofloxacin. Okay. So we should know only the contraindications, maybe 1 or 2, no need for details, all these things. Mainly, that's why usually, as I have seen, in neonates, cefotaxime they are giving because of all these problems, right? He's telling don't use in neonate with hyperbilirubinemia, hypoalbuminemia, and acidosis. In our hospital, usually in neonates, they are using cefotaxime only. I don't see ceftriaxone. Others can comment.
In neonates, along with cefotaxime, even a gram-positive coverage needs to be given, something like ampicillin or amox, because that will not cover listeria.
Yeah, the same thing. Cefotaxime and ampicillin is used in our hospital. I have never seen using ceftriaxone in neonates. Maybe because of this reasons. Okay, one we all know, if there is allergy, we will not give and we will avoid in neonates and with calcium. Why with calcium? Anyone knows the answer?
There is some cardiac that can happen. I don't exactly remember. That's why we were always told not to give.
Okay, so just we'll remember 3 reasons here of calcium, and we will avoid in neonates and if there is anaphylaxis, if they ask. Otherwise, just we'll tell ceftriaxone 100 mg per kg. This is the standard empiric antibiotic. Okay, and if neonate, you will consider cefotaxime. Specific antimicrobials, other you have to consider age less than 1 month and rash and raised ALT and AST. So when do you consider acyclovir? You should know this. So he should be age less than 1 month and rash and raised AST and ALT. You are seeing derangements in liver functions with rash and age less than 1 month, you will consider acyclovir. Age less than 3 months, add amoxicillin high dose IV or ampicillin also, right? If group A streptococcal infection suspected, if you are suspecting group A streptococcus infection, chicken pox or other skin lesions, painful cellulitis, add clindamycin. You will add also along with ceftriaxone, clindamycin. If MRSA is suspected, add vancomycin. If anaerobic infection suspected, add metronidazole. If hospital acquired, give piperacillin and tazobactam. If neutropenic, give piperacillin with tazobactam. So this along with this ceftriaxone, depending upon ceftriaxone or cefotaxime, depending upon your choice, you may need to add some antibiotics if needed, like age less than 1 month and raised AST/ALT with rash, acyclovir. Less than 3 months, along with ceftriaxone or cefotaxime, you will add amoxicillin or ampicillin. Here it's given amoxicillin, so in the exam, better say amoxicillin high dose. If group A streptococcal infection, you will add clindamycin. If MRSA, vancomycin. If anaerobic infection, metronidazole. If hospital acquired and neutropenic, both piperacillin and tazobactam, that is tazocin. Treat with antimicrobials for If no organisms identified or meningococcus, give 10 days of antibiotics. If group A streptococcus, treat 10 days. If staphylococcus aureus, treat 14 days. If meningococcus, discuss prophylaxis with Public Health England, that is ciprofloxacin all ages for close contacts. So whenever there is meningococcus, this question will be asked, right, about the prophylaxis for close contacts. So you will give ciprofloxacin. If anyone remembers, can tell us the dose, and I think it's single dose as I remember, but can someone comment? Yes. See, prophylaxis in meningococcal infection or meningococcal meningitis for close contacts.
It's single dose.
Okay, single dose.
Ciprofloxacin.
So for further investigations, carry out through clinical examination to look for the source of infection. Tailor investigations to clinical history and examination. So always your history and detailed examination will guide you what you have to do. Urine analysis and chest X-ray, aged more than 5 years with suspected sepsis. If no likely source identified, ultrasound abdomen and pelvis has to be done. So you did all the investigations and you are not sure about the cause, you will also do ultrasound abdomen and pelvis. If intra-abdominal or pelvic infection suspected, involve pediatric surgical team. Perform lumbar puncture in the following with suspected sepsis unless contraindicated. Okay. So what is the indication for lumbar puncture? Age less than 1 month. All infants aged 1 to 3 months who appear unwell. Infants aged 1 to 3 months with WBC's count less than 5 or more than 15. Okay, we should know, we should remember this. When do you go for lumbar puncture in the cases of sepsis? So age less than 1 year, you suspect, sorry, 1 month, you suspect sepsis, you will go. And in 1 to 3 months appearing unwell, or if the WBC count less than 5,000 or more than 15,000. So this is the last thing, discharge and follow up. Ensure patient and family carer aware of diagnosis of sepsis. Okay, you will educate the parents and the family. Discharge notification to GP to include the diagnosis of sepsis. Give patient and family carer opportunity to discuss the concerns. That is, you will have a communication with them, communication scenario. Why they developed sepsis, whether they will get it again, recovery, short-term and long-term problems. Give the following information about further tests, community care details, information about support groups. Okay. What support groups is he talking about? Do the patients, means the patients who will have long-term sequelae after sepsis, about these support groups? Any comments? Okay, we are done. Just 1 minute. Okay, if anyone has comments, can go ahead. Today we just went through the purpuric rash algorithm and the management of meningococcal septicemia if they ask. Okay.